That should be better. Yes?
Yep. Now we're good.
Okay, fantastic. Okay, so we're going to talk about nutrition and nutritional supplements today in myeloproliferative neoplasms, because I know this is a huge A, unmet need, but B, interest in terms of patients and what you're reading about and what you're seeing on the shelves. And so my job is to try to help elucidate whether there are good data to support the use of any of these, and also, of course, in case there's any concerns that we should be familiar with. So, quick refresh, we'll start with just an overview of the myeloproliferative neoplasms. Are there any nutritional deficiencies I should be worried about? Should I be following a specific diet if I have ET, PV, or an MF? Are there supplements out there that I should be looking at? What has been tested, what hasn't, and can supplements ever be bad? So just by way of review, and most of you know this, but in case we have newcomers to the group, that the myeloproliferative neoplasms encompass a variety of sort of sub-disorders, which sometimes do overlap. But polycythemia vera is a condition where the bone marrow is overproducing red blood cells, and patients may have symptoms ranging from nothing at all to itching, to night sweats, bone pain, enlargement of the spleen. Essential thrombocytosis, also called thrombocythemia, but not cytopenia, which I was just telling the medical students earlier today. Thrombocytopenia means low platelets. Thrombocythemia is an older term for high platelets. I prefer to use the term essential thrombocytosis just to make that more clear. And the patients generally with ET don't have anemia, but do have high platelets, maybe splenomegaly, maybe a high white blood cell count. Myelofibrosis has now been dissected for us a little bit into prefibrotic myelofibrosis, where the bone marrow looks like it's really trying to pump out more blood cells, but there's this streaming fibrosis starting to occur, versus overt myelofibrosis, which frequently is associated with anemia and can be the long-term outcome of having had polycythemia vera or essential thrombocytosis for many years, or myelofibrosis can be the presenting diagnosis itself. It tends to have more symptomatology as compared to PV or ET, with constitutional symptoms like night sweats, weight loss, sometimes bone pain. And the splenomegaly tends to be, not always, but tends to be a bigger problem with myelofibrosis. So in general, with PV and ET, myelofibrosis to a lesser extent, we're talking about patients who are living for a very, very, very long time, usually decades from the time of onset of the disease. And so we're not as worried about the end result of this type of blood cancer as we are about the complications that can occur while we're walking around with this more or less chronic blood condition. And those are generally what we call thrombosis or blood clotting. That really is the big contributor to morbidity in patients with myeloproliferative neoplasms. And interestingly, this is a big issue, but it's a most common at the time of presentation. So for PV patients, 25 to 40% of them will actually present with their first clot. A little bit lower, 10 to 25% for ET. But even after that initial diagnostic period, we continue to see risk of thrombosis in this disease. It's higher with PV as compared to ET or myelofibrosis. And the sites, especially for the venous blood clots, can be unusual, can affect the liver, can affect the brain even. And then there's a condition that we sort of refer to as microvascular events or microvascular symptoms, which include painful burning sensation in the ear or finger or toe, some part of an extremity that can come and go and will sometimes respond to aspirin, but is not really an overt blood clot that we can diagnose. So how can we prevent the primary risks associated with the myeloproliferative neoplasms, which are arterial and venous clotting? So we do have a few things in our armamentarium, which I'm sure you're aware of. Number one being aspirin. So aspirin is an age-old medication that's available over the counter, whose primary job is to inhibit the stickiness of platelets. Aspirin doesn't reduce the number of platelets, it reduces their function, which is to stick together to form clots. Aspirin has been studied in these diseases and is associated with a lower risk of clotting, particularly on the arterial side. So that's the heart attacks and strokes. But unfortunately, it does have the downside of also being associated with bleeding, particularly in the stomach. So we take our recommendation, even for giving you aspirin, pretty seriously. And of late, patients who have CALR mutated essential thrombocytosis, who are under 60 and have never had a blood clot, we are now not recommending even a baby aspirin in that setting unless you're having those microvascular symptoms or you've already had a venous or arterial blood clot. The next thing that we go to, which has been shown to decrease the risk of these clotting events, are medications that reduce the blood cell counts, otherwise known as cytoreduction. So cyto means cellular reduction therapy. And the primary categories for cytoreducing agents are the JAK inhibitors, such as ruxolitinib, which was first FDA approved for myelofibrosis, but is now also FDA approved for polycythemia vera. The interferons, which we've used for many, many years, a form of pegylated interferon that has several studies supporting its use, but is not technically FDA indicated for these diseases, which is called Pegasus. And now a newer FDA-approved agent, at least for polycythemia vera, and it's being studied in all of the other conditions, which is Besremi. And then lastly, our good old hydroxyurea, which has been around for 50 years now, is an oral, easy-to-take agent that will reduce blood cell counts and has been shown to decrease the risk of clotting, though there's emerging data to suggest it may not be quite as good as the JAK inhibitors and maybe not over the long run as the interferons. The other thing that we've always got to remember to do is to control the other cardiovascular risk factors. So heart disease remains the #1 killer of people in Western society, meaning heart attack and stroke. And all of the usual players really need to be targeted on that for that purpose in patients with myeloproliferative neoplasms. So that means diabetes, controlling sugars, blood pressure, watching the blood pressure, keeping it under excellent control, and cholesterol. These have to be targeted in our patients and our group to reduce the overall risk of clotting. Last but not least, a well-known reducer of heart attack and stroke, both as primary prevention, it's much better than aspirin, and as secondary prevention when it's used after a heart attack or stroke, are the category of drugs given a lot in cardiology called statins. So there were some studies, a French study suggested that there wasn't efficacy for statins in primary prevention, meaning giving it to PV and ET patients who had never had a blood clot. But more recently, in 2023, Podolstev and his colleagues showed from epidemiologic data of thousands of patients, whereas this primary prevention data was a smaller subgroup of one center. But this epidemiologic data suggested that indeed the use of statins appeared to not only reduce cardiovascular events for PV and ET patients, but also to improve survival, or it was associated with better survival. So I strongly encourage my patients, if their cholesterol is elevated, mainly the LDL cholesterol, to go forward with statin therapy. And this often does require us to educate our colleagues in internal medicine and sometimes even cardiology that our patients are considered a higher risk group. So we should be treating them not as an all-comer with low risk, but as somebody who has another synergistic risk factor. Now, obviously, if you've had a bad reaction with statins, then we're not going to push them. But for those who haven't, whose LDL is elevated, I'm definitely recommending the statins. So those are just that's the armamentarium that we have that you're going to find across the board MPN specialists are going to go to with respect to how to reduce your risk of clotting. But I think we have a great interest, since many of our patients don't require cytoreduction treatment at all, in understanding, since I'm going to live for decades with this disease, what are the things that I can be doing on a daily basis? And of course, one of the things we all do every day is to eat. So what do we know about diets that can prevent bad outcomes in these diseases? So there was a very large, many thousands of patients were involved in this PREDIMED study. This was a Spanish study, Prevención con Dieta Mediterránea, or PREDIMED, that was conducted in Europe, looking at what was long felt to be a heart-healthy diet, the Mediterranean diet. They took people, this was not myeloproliferative people, this was just people who had high risk of heart attack and stroke. So they had diabetes, they had high blood pressure, they had high cholesterol. 20 or 30% of them were smokers. These were people that were very likely to have one of these arterial events over the next 5 years over which the study was conducted. So they did not include people who had already had a heart attack or stroke, and they did not include patients with blood cancers like myeloproliferative neoplasm. So that's one caveat. But you could say that there was a similarity in the sense that these were high-risk patients. And they were randomized to one of 3 diets: a quote-unquote low-fat diet, a Mediterranean diet enriched with extra virgin olive oil, which was given to them for free to use at least 4 tablespoons a day, or a Mediterranean diet that was enriched with nuts. And they were given a package of nuts for the month, and they were advised to eat at least 2 servings 2 times a week, or 3 times a week, sorry. So this was sort of the recommendation of the Mediterranean diet: at least 4 tablespoons of extra virgin olive oil a day, these nuts, fresh fruits, 3 servings a day. I realized as I went over this, I do not eat 3 servings of fruit a day. Small servings, but 3 a day, and then vegetables at least 2 servings a day. Fish at least 3 nights per week, legumes at least 3 days per week. So frito is sort of a sauce to put on things. It's got tomatoes and garlic and some fresh herbs in it. And then white meat was recommended instead of red meat. And of course, although there's some controversy about this now, wine with meals in people who were currently taking alcohol of any amount, and 1 glass a night with meals. So you may wonder, well, what is this randomization to this extra virgin olive oil? So extra virgin olive oil is high in a couple of things. Number 1 is oleic acid, which is a monounsaturated fat that has been associated with lowering LDL and raising the good cholesterol, the HDL. Probably or possibly more important is that extra virgin olive oil appears to be very high in polyphenols. And there are certain versions of extra virgin olive oil that are very purified that may have more than others. So they really made an attempt to give these people really good extra virgin olive oil. These polyphenols are felt to reduce inflammation by acting at the gut barrier with bacteria, and to reduce oxidative damage. So polyphenols was the key ingredient here in the extra virgin olive oil. And then why nuts? So why was one group randomized to get a high nut diet? So nuts are also high in unsaturated, monounsaturated fats in particular, also contributing to lowering the LDL, particularly walnuts, by the way. They're high in omega-3 fatty acids, which are felt to help reduce inflammation, high in fiber, which are felt to help you kind of feel full sooner, and high in L-arginine, which is helpful apparently in lowering blood pressure. So there were scientific reasons why these additions to the Mediterranean diet were added, but the investigators weren't sure if nuts were equivalent to EVOO or if these provided different benefits. So they had two different groups, both with the Mediterranean diet, one with the EVOO and one with the nuts. What they found in the end was that indeed, for the combination of heart attack, stroke, and death from cardiovascular disease, the Mediterranean diet was significantly better than the control diet. In addition, the Mediterranean diet, so the line here at the bottom, which shows the very best outcomes with the least number of strokes, heart attacks, and death from heart disease, occurred with the patients who had very high adherence to the diet. So there were patients who were on the randomized, they were randomized to the Mediterranean diet. However, they reported in their diaries that they weren't really keeping up with it as recommended. Those that were adherent to the diet really did shine in terms of their outcomes. So this was very good data. This was published in the New England Journal of Medicine and felt to really support the use of a Mediterranean diet for people at high risk of developing heart attack, stroke, or death from cardiovascular disease. The authors subsequently looked at some other things that might be of interest to us in the myeloproliferative neoplasm. So the PREDIMED study had a subsequent publication on the impact of these different diets on platelets. So overall, as they followed these patients, the control patient, the normal patients who were not given a Mediterranean diet, had a gradual increase each year in their platelet count. So the number just increased. These were not people who had a high platelet count to begin with, but their number just increased with age, which has been reported in other studies. But the 5-year platelet count for the Mediterranean diet enriched with extra virgin olive oil actually dropped by 10 points, and it dropped even more so for the diet enriched with nuts. So that seems like a good thing. But, this is not relevant specifically to myeloproliferative neoplasms. Now, in terms of developing a new platelet problem, so either a disease with low platelets or a disease with high platelets, we did not see any difference in the diet in terms of the 5-year development of a high platelet disorder, such as essential thrombocytosis. But interestingly, there was a significant benefit for the EVOO Mediterranean diet in preventing, or it was associated with less development of a low platelet problem. So both of the Mediterranean diets resulted in lower incidence of a new low platelet problem as compared to the control low-fat diet. And that was kind of interesting because the development of a low platelet problem was actually associated with higher mortality in this study. And so when we look at those with thrombocytopenia, this is all-cause mortality is shifted to the right. People who developed thrombocytopenia had lower, poorer survival. And however, for those who developed thrombocytopenia but were given either of the two Mediterranean diets, their survival was shifted back closer to people on the normal line. So again, we can't say this was specifically a myeloproliferative disorder group, but it was a group that we did see some development of blood disorders. And the Mediterranean diet did appear to abrogate the adverse effect of the development, particularly of a low platelet disorder over the course of the 5 years.
Dr. O'Connell,
Yes.
we did have a question coming in
Great.
asking what nuts are recommended.
Yeah.
I don't know if that was specified within
It
the
was
study.
specified. There were 3 types of nuts. They were almonds, walnuts, and hazelnuts were the 3 types of nuts that were given to the study participants. So that's a
Awesome.
really great question. And walnuts in particular, which I did not know, appeared to have really some of the highest benefit in terms of the monounsaturated fat and
Interesting.
anti-inflammatory properties.
Perfect.
So with respect to this Predimed diet, other publications have come out where they looked at other outcomes over the course of the 5 years. There was a significant reduction in the development of fatty liver disease in the EVOO diet, but not in the nut-enhanced or low-fat diet. So that was kind of interesting. There was also a lower risk of developing a high white blood cell count or a low white blood cell count. So we like the sound of that in the myeloproliferative space. We know, of course, about the lower risk of the different arterial events, but there was also a lower risk of going on to develop diabetes and atrial fibrillation. There was not a benefit for people who went on to require cataract surgery or went on to develop heart failure. So we can't say that this diet is a cure-all, but there's certainly a suggestion that things to do with the metabolic syndrome and with our cardiovascular risk seem to be impacted by uptake of a Mediterranean diet, and particularly with the use of extra virgin olive oil. So my colleague down at UC Irvine, Dr. Angela Fleischman, after reviewing these data, decided that she would try to implement a Mediterranean diet among a small group of patients here in Southern California. So in this particular trial, these are myeloproliferative neoplasm patients, and I think there were 25 or 28 in each group, and they were randomized to receive the counseling on the Mediterranean diet versus counseling on the, USDA recommended diet. And what they found, when they looked at a few things, they really, because the study was quite small, they were really just trying to show that it was feasible for Westerners in America to actually comply with the Mediterranean diet, because the prior study had been done in a Mediterranean place where that diet is obviously more accessible. Now, Southern California has a pretty similar kind of Mediterranean climate, so we have a lot of fish and olives and grapes and that type of thing. But she did find that there was the ability to comply with this diet, which was good. But they did also look at symptoms. The study wasn't powered to give us a statistical result. But if you look here, the patients who were randomized to the USDA regular diet are shown in black, and those randomized to the Mediterranean diet were shown in red. And this is the percent change in their myeloproliferative symptom assessment form. So at week 6, we have a few of the patients, 4 of the patients in the Mediterranean diet expressing a more than 50% improvement in their symptoms, only 2 here in the USDA diet. Maybe those same 2 very optimistic people are still there at week 9. We've got a few more that we've picked up here on the Mediterranean diet. And when you take it out to week 15, the Mediterranean diet does look like it had a much more significant impact in terms of improving symptoms on the MPN SAF, although I can't say that this was statistically significant because there weren't enough patients to make this statement. But it certainly seems promising, as one would expect, that this anti-inflammatory Mediterranean diet may have some benefits for our MPN patients. So that's really all we know in terms of diet, where we actually have some clinical trials that have given us some information. So the best I can tell my patients who ask me, what should I be eating, is I can encourage them to look up the Mediterranean diet and consider trying to implement it. Now let's move over to nutritional supplements. I think we have a question.
Yeah. Just someone was asking, is there any specific quantity recommended for nuts in that Mediterranean diet that was followed in the study?
Yes, I think it was 200 grams. Actually, no, 200 grams were provided for them per month. The nuts was 3 servings per week. And so they had those little packets like the ones that you can get at 7-Eleven. They're a tiny little packet like this. That's considered 1 serving of nuts.
Okay.
And so the nuts wasn't that bad, 3 servings of those per week. So those are felt to be very high. But again, specifically, we're focusing on almonds and walnuts as well as hazelnuts there.
Okay.
Sure. Okay, now let's move over into what you really want to know is where billions are spent per year in the United States and elsewhere is in nutritional supplements. So as you know, nutritional supplements, they don't have the same requirements that drugs, things that are considered actual medications, have in terms of their FDA approval and showing up on the shelf. So they don't have to go through phase 3 clinical trials in people if they are considered a food or dietary supplement. So I'm going to go through a bunch of different supplements that have interest for a variety of conditions and try to see if we can link any data or any information toward patients living with myeloproliferative disorders. So starting with vitamin D. So I use the big D here because vitamin D has mixed messages for us in myeloproliferative. Now, it's been a deficiency, so not having enough vitamin D has been associated with the development of cancer in big epidemiologic studies. It's also been shown to be quite prevalent for people with PV and myelofibrosis, less so ET, being deficient or insufficient in your level of vitamin D. However, there didn't appear to be any impact whatsoever on the long-term outcome for those patients who were deficient. And this was published by Ayalu Teferi's and colleagues in the American Journal of Hematology several years ago. There was also no benefit in 2 small studies of supplementing these folks with vitamin D. Furthermore, there is a mouse model where low vitamin D diet actually prevented the progression of fibrosis in this mouse model. So I think we have to be really careful about making a strong recommendation for vitamin D replacement or supplementation in our patients with myeloproliferative neoplasms. If you have a severe deficiency, then for other reasons, such as bone health and maybe even other cancers, and possibly even for the immune system, it's appropriate to replace with vitamin D. But we cannot say at this time that patients with myeloproliferative neoplasms should be given vitamin D supplementation. Moving forward to omega-3 fatty acids, omega-3, OMG, could it be? So there is a lot of data that omega-3 fatty acids have an anti-inflammatory effect. And in fact, as I just showed, the Mediterranean diet is very rich in omega-3 fatty acids, which come from the high fish content and also the nuts, as I mentioned. And these omega-3 fatty acids may modulate platelet aggregation, but a recent meta-analysis showed that they don't cause clinical bleeding, which is good news because some of our patients with very high platelet counts can actually have increased risk for bleeding as opposed to clotting. So we do have to be careful with any supplements that may cause bleeding, which a lot of supplements meant to decrease the risk of heart attack or stroke are working through platelets, since platelet aggregation is the final step in clotting in a heart attack or a stroke. So there may be some modulation of that platelet aggregation, but no major increase in bleeding. And in mouse models, there was some reduction in the proliferation of myeloid precursors. However, unfortunately, as with many of these supplements, we don't have any clinical trials in myeloproliferative neoplasms, which means that I can't tell you what dose to take. I can't tell you that this is safe over the long term. What I can say is that a diet rich in omega-3 fatty acids would be recommended just in general for cardiovascular risk protection. I have a lot of patients coming to me taking NAC or N-acetylcysteine. And here I put nobody is aware if it contributes because we don't have clinical trials in myeloproliferative neoplasms. We do have preclinical data which seem to suggest it can be an anti-proliferative molecule, and it's a precursor to glutathione, which is a nice antioxidant. So it helps to sop up free radicals that can cause damage to organs in our body. It also has apparently an anti-fibrotic effect in mouse models of lung fibrosis and liver fibrosis. Now, does that mean it also is antifibrotic in myelofibrosis or bone marrow fibrosis? We cannot say. And again, mouse models do not always translate when we test these things in the human. So although I understand why there's great interest in this NAC, and I know that a lot of you may be experimenting with it, I can't recommend it on a scientific basis in humans with myeloproliferative neoplasms yet. So vitamin C, I'm going to say C for cautious. We should be cautious with vitamin C in our myeloproliferative neoplasms. Interestingly, myeloid malignancies in general do seem to have a higher prevalence of vitamin C deficiency, believe it or not. We see that more so in MDS and AML patients, and that was reported by my colleague in Denmark with whom I participated in a randomized control trial of 1,000 milligrams of vitamin C versus placebo for patients with low-grade MDS, not myeloproliferative, but myelodysplastic. So similar, a lot of the same mutations, but these patients tend to have low blood cell counts, not high blood cell counts, and they can go on to develop more aggressive disease and AML. We actually found a survival benefit, seemingly from a reduction in infection in our low-grade MDS patients. So that seems very exciting, very promising. However, I can't say that translates to the myeloproliferative neoplasms, and we do have to be careful with polycythemia vera in particular because vitamin C is an acid and it can enhance the absorption of iron, which if you're undergoing phlebotomy for polycythemia vera, we're actually trying to induce iron deficiency on purpose. So we don't want to recommend things that will enhance iron uptake. So I can't say that we have a trial for vitamin C yet in myeloproliferative neoplasm, so I would advise some caution there. Quercetin. So quercetin, I think, is a good question. Quercetin is a food additive that appears to, in the laboratory, promote apoptosis or cell death of rapidly proliferating cells, which we know is what's happening with our myeloproliferative cells. And it appears to directly inhibit JAK2 mutated cell lines, again, in the lab, as well as one of the various promoters of fibrosis called TGF-beta. So it may have some anti-fibrotic properties. So I personally think quercetin is a good question that we should be studying this in a clinical trial. It seems to have some really positive preclinical data, but unfortunately, I still can't recommend it or its descendant isoquercetin because we don't yet have clinical trials specifically showing a benefit for myeloproliferative neoplasms. Similarly, resveratrol, which is the antioxidant compound in grapes and wines, is available as a very concentrated substance that you can buy over the counter. Resveratrol has been studied quite a bit in the laboratory, and it seems to impact and inhibit cancer cell development at various different levels, not just at one enzyme. DNA repair, antioxidants, anti-inflammatories, apoptosis, inhibition and modulation of some of your innate proliferative regulators. And so it really also has quite a bit of good potential for study. However, we don't have good clinical data in the myeloproliferative neoplasms. We also need to be very careful because there are some data suggesting resveratrol can not only be antiplatelet in terms of keeping platelets from being sticky, but may even reduce the platelet count. So we do have to be careful with its use in some of our blood cancer diseases until we see some clinical trials. But I think like the quercetin and isoquercetin, this resveratrol may have some promise. Okay, moving forward. So curcumin, it's coming because we are doing a clinical trial with this particular compound. So curcumin seems to have a lot of different potential impacts. And what caught my eye was a small study that was performed in patients with something called MGOS, which is the precursor condition that can move into, over time, multiple myeloma. And this group studied 2 grams, which is a very high dose, twice daily in a clinical trial of people with high-risk MGOS that had a big chance of going on to develop multiple myeloma. And they were able to show that they could get this dose of this compound into the bone marrow, and that there were some patients with particularly a high bad protein marker that they were able to lower that protein marker in. So this caught my eye as something that could be of interest to us, because in addition to already having some clinical data showing safety, we know from the laboratory that it's anti-inflammatory. It can inhibit STAT3, which is the downstream next molecule that JAK, when it's mutated, activates. It can decrease NF-kappa B, which is felt to be another inflammatory cytokine that's at work in our myeloproliferative disorders. And then it's also been tested in other disorders like obesity and inflammatory arthritis, where it was shown to decrease some of these inflammatory markers. So on the basis of those findings, as well as our own findings, which I show here, where we took leukemia cell lines in the laboratory and we exposed them to a bunch of different agents. This blue line here is DMSO, which is basically exposing them to nothing. We tried isoquercetin in this group at 2 different doses. And then we used curcumin. Now, curcumin at the higher dose, shown in teal here, completely killed all of the cells. So we actually had to use a lower dose in order to see if we could figure out what it was doing and what was the mechanism of it to destroy these cells. And these are 2 different leukemia cell lines. So at the high dose, they were all gone. At the low dose, it was still better than the other agents. And we were trying to figure out, was it causing a change in methylation, which we were not able to show, but it did seem to have some cancer-fighting properties in leukemia cells. And how do we think it works? Well, we think it blocks some important things like beta-catenin and Gli1. It blocks cyclin D1, which is part of what makes your cells continue to go into cell cycle so that they're proliferating. It also seemed to block some of the anti-apoptosis. So these are markers in your blood cells that stop the cell from dying, right? So if we have a cell that's gone awry, we want that cell to undergo programmed cell death. And sometimes these markers will turn up, and so the cell doesn't undergo the programmed cell death that it should go when it starts going haywire. And the curcumin seem to help block those. These are in other people's laboratory data. And as I mentioned, NF-kappa B. And then it seems to promote some of the apoptotic cascade, like caspases, and other cell cycle inhibitors that keep your cells from being on overdrive and overproliferation. So we have kicked off, on the basis of these findings, a randomized trial of curcumin versus placebo. So 2 patients will get the curcumin, or are getting the curcumin, for every 1 patient that gets a placebo pill over a 12-month period. And we are evaluating patients' symptoms at the beginning, at 3 months, and at 1 year, as well as a whole panel of cytokines, inflammatory cytokines that we're testing in their blood, because we think symptoms correlate with cytokines, and we think this particular food additive or nutritional supplement has the ability to downregulate some of these important cytokines. We are testing this in patients with both myeloproliferative neoplasms as well as low-risk MDS. As I mentioned, we tested that vitamin C in. And if you have any interest in participating in this trial, we'd love to have you. You have to have symptoms associated with your MPN and be either on no medication or a stable dose for a long time of a cytoreductive medication. And my contact for the study is isayed@med.usc.edu, Abraham, and he'd be happy to help get you some more information if you're interested. And by the way, turmeric, I think, is what people are most commonly taking. Turmeric, the active ingredient that we're all excited about is the curcumin, which comes from a root, Curcuma longata. So the turmeric that's given over the counter does contain the curcumin, but we're studying the curcumin in its pure form with biopurine, which is a pepper that helps to enhance the bioavailability, since your body will very quickly degrade curcumin that you take naturally. I do have some cautionary tales. So not all food supplements or dietary supplements are benign, and some have been studied in other cancers with some concerning findings. One example of this is folic acid. So folic acid had a lot of promise for having some anti-cancer benefits. 1 milligram a day of folic acid in a study of 60 Greek patients with a lot of polyps showed a 40% reduction in the recurrence of polyps in the colon if they took 1 milligram a day of folate. There was also some evidence in a mouse model that physiologic doses would reduce the development of colon cancer. And then in the Nurses' Health study, women who were taking a multivitamin that contained folate, which is generally low dose, had a significant reduction in colorectal cancer risk. However, in the 80s and 90s, there was a whole movement to give these very high doses of folic acid, 2.5 milligrams. And this was often recommended by cardiologists. It was thought to reduce the incidence of coronary artery events and strokes. But unfortunately, we have several pieces of evidence that suggest that higher dose folate is not a good thing. So after high dose folate supplementation was rolled out in the US, Canada, and Chile, there's been an increase in colorectal cancer risk. Now, this is just epidemiologic data. Other things have also happened over the same time period, so we can't be 100% sure it's the folate. But in mice with breast cancer, there has been an increase. They've shown an increase in progression of the breast cancer that when they took folate out of the diet seemed to get better. And super high dose folate, like the 2.5 milligrams, which is way more than recommended in a regular diet. Regular diet is less than a milligram. This is 400 micrograms, a very small amount that's in a multivitamin. High doses actually cause mouse polyps to increase the risk of transformation to colorectal cancer. So this is a real promise or peril, because you can certainly buy high dose folic acid over the counter, and I recommend that you do not take high dose folic acid, not because of myeloproliferative risk, but because of other cancer risk issues. Another cautionary tale was there appeared to be some interest, at least in the mice and in the preclinical data, in vitamin E and beta carotene in reducing the risk of progression of some cancers. In particular, there was excitement about it reducing lung cancer risk in smokers. So they did a randomized controlled trial with beta carotene supplementation, and unfortunately found that there was a higher risk of lung cancer development in the beta carotene treated patients who were smokers. So this was definitely not what was intended by the investigators, and a real disappointment. In addition, there was a slightly higher risk of development of prostate cancer and higher deaths from heart disease in the patients supplemented with beta carotene. So although this is another food supplement that you can buy over the counter, I do not recommend supplementation with beta carotene for our patients. Okay, so that's where we stand. We have a very, very, very great need for further studies. I've come across several articles now, including going through ChatGPT, where my curcumin study was the only randomized trial listed for patients with myeloproliferative neoplasms who are interested in participating in a nutritional supplement study. So that's really, unfortunate because I know it's a huge interest and more than half of our patients are taking supplements with the intent of lowering risk related to their disease. I would encourage you to participate or encourage or donate to clinical trials in this area because this is what you care about and you're interested in, and you have the power through things like HealthTree to really try to drive research towards what you want to see done. And I personally felt that this was really important. So many of my patients were asking about it, and I was very fortunate that one of my former myeloproliferative neoplasm patients, who unfortunately did go on to develop acute myeloid leukemia after many decades with the disease, he did leave us a big fund for research, and I've used that funding to support the curcumin study because that is a type of study that a drug company isn't going to fund because these studies are expensive, especially to randomize them. And if they don't stand to make, millions of dollars, it's not worth their investment. So I'm using those funds to support studies that I think people really care about that I don't think would otherwise get funded. So now I want to move on to another area of great interest. Many of you might be considering or taking probiotics. So probiotics are capsules of bacteria. These can also be found in yogurts, but you can buy them as a capsule. That are meant to sort of reset or restore normal gut flora to the person's GI tract. And these gut flora, there are hundreds of millions of bacteria living inside of us that have been associated in some cases with more inflammation or with the development of autoimmune diseases. There's even some relationship to the likelihood that immune therapy is going to work for a patient, depending on their gut microbiome. So a lot of interest in this area. Very difficult to study because there's hundreds of millions of these bacteria. How do you know which ones and how many? So really, it's a statistical nightmare trying to get into this problem of the gut microbiome. Yes, we have a question.
Yeah. Just before we move into the gut microbiome, we had a few questions around supplements that I thought we might want to address now.
Okay.
Um, First up is asking about calcium supplementation and risk of heart disease, or is calcium supplementation recommended at this point for MPN
Yeah.
patients?
So it's not specifically recommended for MPN patients. There is some concern now in the cardiovascular health community that increasing calcium supplementation, because when you make a plaque with cholesterol on a blood vessel, it's actually the calcium that hardens on that plaque that ends up being the thing that makes it rupture. So there's some concern that we've had a move toward over supplementation with calcium in our population. If you do a CAT scan of somebody's heart, you can see calcifications develop in the blood vessels. And in fact, there is a risk score that can be generated by what's called a calcium CT scan for heart disease that's based on the amount of calcium that's in those blood vessels. So I would advise caution with calcium supplementation unless there is a reason for you to be taking it, such as osteoporosis, osteopenia. This is a condition of bone demineralization that people do need vitamin D supplementation for, and often vitamin D will also contain calcium. People who are actually being treated with bisphosphonates for osteoporosis also may need to be on calcium because the medication is going to pull calcium into their bones. So yeah, these are things you do want to be careful about. I do not across the board recommend calcium supplementation at this point for our MPN patients.
Okay. And we have a few more supplement specific questions. Nicotinamides,
Yeah.
um, any information on those?
Yes, I'm sorry. I did not look up the nicotinamide, so I don't have a lot to tell you. Niacin is something that has been used to lower the lipoprotein little a. And, cardiology's finally caught up to the hematologists. We've been worried about lipoprotein little a for decades now. And so that is one of them that can lower it, but you have to take really high doses. And I would say only 10% of people can tolerate it because it causes flushing. But I don't have a lot of data on the nicotinamide. Sorry about that.
No worries. Another one. Garlic supplementation with baby aspirin. Is that too much for anticoagulation?
Mhm. Yeah, so again, garlic as an additional supplement, we don't have MPN data for that. We clearly, though, in the Mediterranean diet, the sofrito, that's a garlic infused kind of oil and tomato sauce. And so garlic does appear to have some additional benefits in terms of cardiovascular health. Um, if you are taking garlic with a baby aspirin and you're noticing an increase, and this is true for all of the, good for the heart supplements, if you start to notice an increase in gum bleeding, nose bleeding, you do probably need to back off because the supplementation, it's difficult for us to know dosing and exposure for these things because they don't require such rigorous testing by the FDA. And so it's sometimes hard for us to know for sure if you're getting too much, too little, what the right dose is, and whether there's dosing similarity across the different supplements of that same compound. So I would base it clinically. If you're having bruising or bleeding, then it's definitely too much. If you're not, I can't really say for sure. I would probably always vote for a garlic enriched diet over garlic tablets. But I'm not aware that there's any reason to, strictly avoid the garlic tablets.
And then finally, I have two asking specifically about in the context of PV. So one is asking about vitamin B12 supplementation, and then the other is any information taking ECGC, which is derived from green tea extract.
Yeah, yeah. Yes, I did come across some preclinical information on ECGC many, many years ago. I did have a patient who was taking it. She had very high platelets and did not want to be medicated with any of the usual cytoreductive agents. Although at first it looked like her platelet count came down a little, it didn't have any durable benefit for her. And the preclinical data there's some similar data as what we see with the quercetin, that there may be some efficacy, but I don't have clinical data, unfortunately, so I can't recommend it. And then for B12, B12 is very interesting. So B12, an elevated B12 level used to be a diagnostic criteria for the myeloproliferative neoplasms because the majority of patients actually had high serum B12 levels. Now, whether that's because there was this turnover of all of these cells that contain B12, I don't think is totally clear. But generally speaking, our myeloproliferative neoplasm patients don't require B12 supplementation because they have high B12 levels. However, I do think it's important to test the B12 levels over time because I have had a couple of patients where 18 years into the disease, I'm not thinking about B12 anymore, but if there's a new anemia, we've got to go and work it up just like anybody else. We should be ruling out B12 deficiency, ruling out iron deficiency, looking for copper levels, just like we would anyone else who develops a new anemia. So, it is okay to check B12 levels, maybe every year, every 5 years in a myeloproliferative patient, because it is possible to miss someone who does develop it by chance over the course of having the disease.
Okay.
But I wouldn't
And
supplement without a low level. It's not going to hurt you. You urinate out B12, unlike vitamins A, C, D, and K, excuse me, A, D, E, and K, which are fat soluble. You don't urinate out the excess. So you don't want to take too much A, D, E, and K. But for B12, you do tend to urinate it out. We're not really aware that there's any major downside of having high levels.
okay. And then if so, I know with B12, one of the common mutations is the MTHFR.
Yeah.
Would that change your perspective on that?
Yeah. So MTHFR mutations really have not been associated with an increased risk of thrombosis. There was a whole, 15-year period where this was all the talk, and it started to be tested in everybody who developed blood clots in unusual places or at a young age. But in the end, it turned out that these mutations did not appear to predict for an increased risk of clotting unless your homocysteine was very, very high, greater than 20. So I know there's been a lot of interest. I know there was a lot of data. It's in the hematology community, it's almost never checked for because the data don't appear to support that it's clinically relevant.
Okay, good to know. Thank you.
Okay. So just heading back here to the mod, I am not a gut microbiome expert by any means, but I thought that we could delve just quickly into what do we know. So investigators have studied the fecal material, the poop of myeloproliferative patients. And although there doesn't seem to be a drastically different gut microbiome, there was one species in particular, this Phoscolarcobacterium, which generally is anti-inflammatory, and there appeared to be fewer of that class of species in patients with myeloproliferative neoplasms. So maybe there's a role for the inflammation and the lack of this particular gut bacterium. And then on the other side of the equation, Parabacteroides and Veillonella seem to be associated with more TNF in the patient's blood. And if the more fruits and vegetables that you take, the more you can reduce at least this Parabacteroides and maybe potentially achieve a lower level of this inflammatory cytokine. But we don't have data to show that that's the case. What we do have is Dr. Fleischman's study that I mentioned, the nutrient study. They did do pre and post fecal samples, and they did look at the gut microbiome with this Mediterranean diet, and there appeared to be no change in the gut microbiome after 12 months on the Mediterranean diet. So now maybe it wasn't enough time. They didn't have the extra additive, nuts or send them the bottle of the extra EVOO. So maybe there are other reasons, but at least at 1 year, and remember the Predimed study was 5 years, but this was 1 year. So at least at the 1 year time point, we don't see a major impact on the gut microbiome by the Mediterranean diet. So in summary, I really beseech you all, we need clinical trials. We want to provide this information for you. This is stuff that you want to know and that you need to know, since it's everywhere at every Whole Foods and Trader Joe's and whatever. We want to know, what could we be eating, what could we be taking, but we need clinical trials. I'm pretty stringent that way. I don't recommend anything. I'm not recommending curcumin. I'm doing a clinical trial to test it, and then I'll publish the data, and I'll be very happy to let you know how it goes. I think that's worth studying. I do think the Mediterranean diet, they've put the effort and the money into studying it, and it does look like it works for prevention of cardiovascular events in high-risk populations. So, it's close enough to the population that you're in if you have the JAK2 mutation in particular. And also the MPL mutation, the TET2, the DNMT3A. It's worth looking at the Mediterranean diet. Dr. Fleischman was able to show that it might even help with symptoms. So I think it's worthwhile for sure. Oops, sorry. Sorry about that. No, I don't know. Can you still see my screen? There we go.
Yeah.
And curcumin is under study here at the USC Norris Cancer Center. We are going to look as a secondary endpoint, given what we found in the laboratory, at whether we can reduce people's mutation burden or not. And then lastly, this microbiome, this is an area for research for sure. I hope that we can get more information. I myself am fascinated by this, would love to know more. But we really do need more study. We need very specific patient populations to really understand. Maybe there's a single probiotic supplement we should be taking. But I'd like to see the data before I recommend it. So that is the end of the talk. If there are any other questions, I'd be happy to take them.
Excellent. That was wonderful, and I really liked your shout out for not just your clinical trial, but really the necessity to have more clinical trials in this space because, as you said, so many patients are interested in this type of work, and people are able to buy these supplements kind of wherever. So there really is a need in this space for more research here. We did have a few other questions that I wanted to address. Um, First up was, are there any dangers in taking GLP-1 shots
Yeah.
when there's active? This person was actually asking in the context of myeloma, but I would love to know in context of MPNs, um, especially if they don't have diabetes.
Yes, there was just an abstract where they looked at, I think it was at ASCO, where they looked at the use of GLP-1s across myeloproliferative neoplasms. I don't have the data in myeloma. I bet it's out there, but for the myeloproliferative neoplasms, it appeared to be a positive association in terms of the risk reduction for
Okay.
heart attack and stroke, which is what we would expect. That was its intended use for diabetics. Was to help control the diabetes and prevent the cardiovascular events associated with long-term diabetes.
Okay, good to know. Next up, we have an individual asking if you have any thoughts on nattokinase.
Yeah. Nattokinase is another one that is being studied. I don't think we have any clinical trials ongoing, and I'm sorry I did not prepare that one for this particular talk. I believe that there were some abstracts showing improvement in symptoms related to deep vein thromboses and post-phlebitic syndrome. So there does seem to be an anti-inflammatory effect there. So I think that would be another one we would really want to see a randomized clinical trial in our MPN patients. Now, in
Uh,
order to see if the clotting effect is active, you've got to study the patients for a much longer period of time, unfortunately, which of course costs money. It's also a lot for the patients to submit to. But that sure would be nice to see a 5 or 10 year study with some of these supplements in terms of whether they don't just help with symptoms and cytokines, but maybe also reducing cardiovascular risk.
um, and it looks like that's going to be it. So thank you so much. I know we're a couple minutes over, so thank you for your time and sharing a little bit of extra time with us. We really do appreciate it.
Okay, thank you. Sorry if I ran over. I'm just realizing I don't have a clock.
Oh, no, we appreciate it. Just more want to make sure you're good on your end.
Yeah, sounds good. Well, thanks everybody. I really wish you well in your journey with MPNs. Take care.
Thank you again. All right. And as you get ready to leave today, I did want to let everyone know about a few more upcoming events that we have coming up. On November 4th, so tomorrow, we have Overcoming Insurance Pre-Authorization Delays and Denials, a patient guide to faster blood cancer care. On November 14th, we have Empower Your Mind, journaling to build resilience for patients and caregivers. And then on November 18th, we have our latest in our community gather event series. And this one is going to be Thankful for Today, a time to reflect and connect. If you are new to the Community Gather series, these are just an opportunity for us to get the MPN community together, kind of share experiences, meet one another, and just ask questions so they do not have a doctor or a formal speaker. It's just really an opportunity for you to get connected with some other individuals. So, highly recommend checking those out if you are interested. And then, if you're looking to connect with people, I do recommend our it's called Connect. It's a social media platform that we run here at HealthTree. These are disease specific, so I have the link for the myelofibrosis one. We should also have a PV and an ET specific one as well. And these are just a place for you to connect online with other individuals who kind of understand what you're going through. So, really recommend checking those out. They're a really good place to just connect and form that community feel. And finally, I just want to thank you all for joining us today and being present here. Um, it means a lot to us. So I really do appreciate it. I've included my email here on this final slide. Feel free to reach out to me at any point in time with any questions. I am always available to members of our community. I am going to stay on for a couple of moments. If you have any questions that you would like to ask me, or ask about HealthTree, or if you want to just maybe speak with some other patients who stay on. So I'll go ahead and turn the recording off. But if you'd like to stay on to chat, I'll keep the call open for a few moments. But thank you for your time.
Hi.